The chairpersons are Dr. Arup Rai and Bhaskar Mani Chatterjee.
Good morning to everybody. Myself and Sir Dr. Bhaskar Mani Chatterjee are chairing the session. Today's topic is the biologics in asthma, the way forward. This is the current topics regarding the treatment of the asthma, and the subject will be dealt other than by Dr. Prasad Kumar. The session is for 20 minutes. Please go.
Thank you. Good morning, all. Really honored, and I really appreciate the opportunity to talk about the role of biologics in asthma. I think one of the things which we need to focus on is the assumptions for this talk. I'm going to assume that we are thinking about a child, school-age child, who's got really severe asthma, confirmed diagnosis. And the key is I'm going to focus an initial bit of the talk only on the practice in the UK, particularly when it comes to prescription of biologics. So we are going to assume that the child is school age and they're on high-dose inhaled steroids. And along with that, they have been prescribed other additional asthma medications, and despite which they have really poor asthma control. They continue to have asthma attacks. And what we need to understand is that the severe asthma, however you want to call it, as therapy-resistant asthma or severe difficult to treat asthma with sort of a severe component, it accounts for a very small portion of our asthmatic population. And the question is, pertaining to the topic I've been given, why do we need a biologic? I think we know, as Satish was saying, asthma per se, particularly severe asthma, is a heterogeneous disease. You cannot treat everyone with sort of a one kind of, in a way, route of therapies. And we are moving more towards personalized medicine, so we need to choose the right drug for the right patient. And the whole aim is for us is to avoid admissions, asthma attacks in children, so that they can live healthier lives, their quality of life is better, and also for the family. So for the sake of the talk, initial bit of the talk, this is where asthma biologics are currently prescribed. In a school-age young person who has got severe atopic asthma, high FeNO, significant bronchodilator reversibility, that's despite being prescribed really high dose of inhaled steroids. You're looking at kind of a 500 microgram of fluticasone equivalent per day. So that is really high, along with other medications, despite which the child continues to have asthma attacks. And most of them, they are highly sensitized to aeroallergens with high IgEs and also eosinophil count. And the number of children we see, despite being prescribed, they have very fairly obstructed sort of an spirometry. So this is, someone who had sort of an FE1 of 52, it just goes up to 58% on bronchodilator reversibility, really obstructed picture. And what we also need to realize is for the prescription of biologics, this is what it's used. When you say high-dose inhaled steroids, in a school-age child, younger child, it has to be more than 800 microgram of beclomethasone. So think about the number of patients you have in your practice who are prescribed this high doses of medications and still continue to have asthma attacks. And the other key element is currently the biologics are still prescribed as an add-on therapy. So this does not replace, the child has to continue on all the standard asthma medications, which is really kind of important. And you also made sure, as Satish was alluding, that you have corrected all the modifiable factors before you think about giving them the biologic. And most of nearly all the asthma biologics currently available, they treat the type 2 inflammation. And what we have here is sort of the current targets for biologics are IgE, eosinophils, you got IL-4, 13, and 5, along with TSLP. So what you're seeing here is when you have this airway epithelium here, on exposure to a lot of insoles, it secretes a lot of cytokines, epithelial cytokines, which results in quite a lot of downstream effects. And what the biologics do is that they target this downstream effects. But we are moving more towards biologics, which are now being available, which targets much more at the higher up level of the sort of way of your epithelium. Briefly, I'm just going to talk about, omalizumab. We know we have significant experience with this. It's been available since 2009. And it blocks the free IgE. It's useful in atopic asthma. All the biologics which are available are given subcutaneously every 2 or 4 weeks. And then it does have a good response. Children who have high FeNO, children who have recurrent episodes of asthma attacks, they tend to respond better. Anti-IL-5 biologics have transformed the adult world, but from our point of view, in pediatrics, just targeting eosinophils, because you got your IL-5, which is necessary for recoupment and survival of eosinophils, and when you have a mAb like mepolizumab, which blocks it, then it prevents the detrimental effects of the eosinophils sort of in a way exploding. But the data in pediatrics is very poor. Clinically, we don't see much of a response in children using sort of in a way anti-IL-5 biologics. Dupilumab, it's been licensed recently, and given a choice in our population, I think this is a biologic which I would like to use because it's known to improve spirometry, it improves their FEV1, improves the quality of life, reduces asthma attacks, and more importantly, because it targets quite a lot of other factors, it does result in improvement of other comorbidities like eczema and atopic rhinitis. So with one drug, you're able to improve sort of in a way more than one type 2 diseases. And in our population, there is some data showing that sort of in a way, when we looked into 34 patients who are on biologics, as you can see, really small numbers, but it results in quite significant reduction in asthma attacks once you start them on and after that. And more importantly, as you know, the markers, whether the quality of life or asthma control, it does improve. And in adult world, there have been a lot of discussions around the importance of talking about asthma remissions. You know, we talk about remissions in a lot of other diseases, whether it's cancer or rheumatological conditions. Now, there is a lot of work going on where we're talking about asthma remissions using biologics. So this is a big, big advance and a big shift in the way how we are thinking about severe asthma. In terms of you're not only looking at controlling, but actually kind of in a way resulting in remission of these patients, which I think is a big, 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 big thing. It's also important to work out that we are also looking at the role of these biologics as a disease modifiable factor. So hopefully in the next 5 years, there's going to be more data about it. So that's like a prelude, which all looks very exciting. But let's come back to the reality now. Because we know asthmas are very different. The asthma, what I deal here is completely different to perhaps what you guys see. Asthma changes with age, it changes with geography. Even in 100 meters sort of a distance, of a 100-kilometer difference, you might see a different population with different severity of asthma. That happens all the time, everywhere. I mean, UK has a population of 60 million. Most of the states in India has population more than that. And you can see that it's how heterogeneous. Someone might say, no, I don't see this disease at all, severe asthma, and someone might say, no, I see quite a lot, because it changes. There are a lot of other epigenetic factors which influence. And the key for us is the underlying mechanism is still poorly understood. And for us, the important bit, particularly when it comes to the biologics, is where are we targeting? So we're all talking about European and American societies where these drugs are available. In our health system, it's available free. It costs 30,000, 40,000 pounds per child per year. It's given out free once we sort of decide the child needs to go on, but the health system is very different. And more importantly, as you can see, most of the asthma-related mortality occurs outside the European country. And of course, biologics are not the answer. As Satish was saying, it's not sort of in a way doing a spirometry or not available. I think it's the basic asthma care, which is really important for us to focus on so that we can then identify those who do not respond to your basic asthma treatments, and then you can escalate. And again, it comes back to the definition of what we mean by severe asthma. As I said, the severe asthma for me is someone who's on high-dose inhaled steroids despite continues to have asthma attacks. But if you look at WHO has recognized it, in a lot of countries, severe asthma is when they have sort of more than 4 attacks. And it could be because they haven't sort of had access to the basic asthma treatments. And again, this is a very nice study which was published recently looking at the sort of a GAN-1 definition of severe asthma. of having more than 4 VZ attacks in the last 12 months. It's done in India. And what's interesting is that if you look at this graph, I'm sure it's visible, those who were diagnosed with severe asthma, most of them, they were not on any basic asthma treatment at all. So is their asthma severe because they are not on any treatments? Or is it actually true severe asthma because despite whatever you give the treatment, it's still, they might have symptoms. So that's something which we need to focus on. Or it could be that the disease is so different that the currently available biologics may not necessarily, which are all targeting your Th2 high, may not necessarily work on the other group, which is really important for us to understand in the local population, rather than just trying to see whether any of these available drugs work in this population or not. But there is some light in the tunnel. There is the new biologic called tezolizumab, which has been licensed last sort of a couple of months ago, currently in UK for children 12 and above. And it's supported by really good adolescent and adult data, which is published in recently. And the key is with this drug, irrespective of what your biomarkers are, whether your eosinophil is low, whatever your FeNO is, it looks like this drug reduces asthma attacks universally. But again, it is quite expensive, and how it sort of, we need more data, and particularly in the pediatric population. So just to finish off with the last 2 slides, I think where we are is very exciting. Of course, we have to move towards personalized medicine. You just can't keep on treating everyone with the same drug, particularly when advances have been made in other disease conditions in adults and pediatrics. But the problem what we have is the currently available biologics, they treat only those who have high T2 inflammation. And then there is lack of evidence along the efficacy, particularly in children, but also what biomarkers you use. And as I said, they're really, really, really expensive drugs. And it's still used out of desperation. And then the key for us is, what about access? You know, it applies to cystic fibrosis, CF modulated drugs. What about access to where it's actually necessary, where the burden of disease is very high? And as I said, there are still drugs which have been licensed without robust pediatric data. And there have been some concerns, although I think sort of probably it's more theoretical, that what happens to using these biologics very earlier on, particularly the anti-eosinophilic drugs, because eosinophils, they are there for a reason in the body, we need them. So what's the effect long term if you keep using it in sort of, in a way, younger children? But most likely that this is perhaps just a theoretical risk, but that's something which we need to be aware of. And there's a lot of work going on, as I talked about, disease-modifying effect, and more importantly, using the word remission, which we have never ever used in asthma before, that can we use the background medications starting on biologics. There are some studies going on in adults, and I'm hoping in the next 5 years, probably, I think there are certainly with a couple of biologics, there is probably a possibility that by starting them on, you might reduce their asthma medications. And more importantly, there are biologics which have been trialed out where you can have 1 injection every 6 months. So which is going to be quite transformational, but again, these are all directing your T2 high asthma. So in my view, the way forward is we really need to start learning from other diseases. In pediatrics, you got cystic fibrosis, rheumatological condition, where people are moving more towards personalized treatment. And the key, again, is focus on the basic asthma treatment. And more importantly, we think what we know is great, but does that what the patients think? What do they think their outcome would be? And I think for us, it's really important to get some local data in this population. You cannot cut and paste what we see in other places. And then the key for us is, along with doing clinical trials, it's also about making sure that there is good collaboration so that we can learn and then probably create more noise in terms of highlighting this issue. And more importantly, I think the key is, rather than finding patients who fit the currently available biologics, I think we need to just turn it around and look at how can we develop interventions or medications which help our population, because the numbers are very, very huge if you look at the general asthma population. So, and then the key for us is, again, yes, it's interesting to see how, say, for example, the last drug I showed, tezepelumab, which is brilliant, but there is no data. We are involved in some clinical trials in 6 to 11-year-olds, but there is very little data. So just licensing these drugs without robust pediatric data based on the adult disease is very different, because I think the adult severe asthma is very different to the pediatric severe asthma. And again, thanks for the opportunity. I'm very lucky to work with these fantastic people, and thank you.
Thank you, Dr. Prasad, for the nice elaboration of the biologics in asthma way forward. He has explained to everything. Just couple of minutes left. Any question from the audience? One or two questions?
Thank you, Dr. Prasad. Lot of these severe asthmatic children, they have got non-T2 high phenotypes. Now, most biologics, they are being targeted for T2 high. So what we have in store, what is the current status of management of these non-T2 high phenotypes?
I think, yeah, very good question. Most of them, I think they still respond to inhaled steroids. There have been trials of antibiotics, but there's never been, azithromycin, which is a magic drug for everything. But even in asthma, it hasn't shown much of a response. But there is some work going on, particularly, I think, looking at some of the preclinical data from tezepelumab. There is likely that this drug might work. But for general population, particularly in pediatrics, T2 low asthma, I think sort of in a way, it needs better definition, because we have just used the definition from adults. And I think probably with time, we'll understand better. But the bottom line is, even your T2 low asthma, unless you're dealing with very severe disease, they still respond to inhaled steroids. I think the basic asthma management still should be there.
Arudha? Yeah. Dr. Prasad, thank you very much. Just one question, yeah. So at your center, what is your experience with biologicals? How frequently you are required to use it, and how many times you are required to go beyond omalizumab?
I think it's very rare that we go beyond biologics nowadays. I think mainly because we are probably getting better at identifying the comorbidities. If a child has, obviously we are all seeing every child getting kind of anxiety and stress. And at school, some of these symptoms are kind of in a way attributed to asthma, which may not be necessary. So we are good, probably not good. We are getting better in identifying the comorbidities and managing them. So having a multidisciplinary assessment of these children, rather than just focusing on the disease and hitting them with medicines, involving the right people, talking to school, involving psychologists. We have a fantastic youth worker who works with some of the adolescents and trying to make them understand the disease better. I think that has changed, that perhaps has helped. And we, because we are a specialist regional center, we get probably around sort of 10 referrals every month with severe asthma, those who are already on that high dose medicines. But I think only 1 in 5, they go on biologics. The remaining, we are able to identify some modifiable factors, and with time, they improve.
I am Dr. Ruhul Amin from Bangladesh.
Thank you.
Dr. Prasad, please tell us about the experience of MART therapy recommended in the recent literature, especially GNA literature.
Simple answer is, in UK, in pediatrics, we are not following MART therapy yet because our guidelines hasn't changed. So, but we are involved in a trial because, unfortunately, the BTS or NICE, they all need local data before they change the practice. So we are still carrying on with daily therapy. Unfortunately, I can talk about it, but personally, we are not using MART yet.
In step 1, do you use inhaled steroid with short-acting beta-2 agonist?
Yeah.
Thank you.
I think time is up.
Just one question.
Yeah.
We have a set of children who are asthmatics who are, well controlled. The ACT scores are good. they don't have exacerbations, they are on steroids. However, when I look at the lung functions, they're developing a fixed small lungs. So is there any role of biologicals in these children?
That's a really good question. I think dupilumab, it's known because that has quite robust data, and that's one thing, because I completely agree, because I mean, one of the slides I had was, if you don't intervene at that stage, then there's a risk that they might develop COPD in early 20s. So I completely agree that your other biologics, they're not that effective unless the patient has exacerbations. But dupilumab perhaps is going to help in terms of improving lung function.
Thank you. One question, what is your personal experience regarding the using of the biologics in asthma, and which type you get more result for the treatment?
I think it is, we need to move towards, personalized medicine. And because of the type of disease, as I said, it's very different. I mean, as I said, the disease is very different in different parts of the world. And the type of disease we see in our patients with severe disease, it has transformed them. It has changed their lives.
To conclude, good morning everybody, because for the initial delay in communication, however, it went on very nicely, and questions also asked, answers also given. So again, come again in Kolkata, in further any conferences, etc. Thank you.
Thank you, sir.